Sanjana. I call upon Dr. Hilda, cornea and phaco surgeon at Little Flower Hospital, Angamali, Medical Director of Eye Bank Association Kerala and Corneal Subcommittee member of KSOS to talk about the DSEK.
Good afternoon all, and thank you Ashwati for the opportunity. The breathtaking beauty of Taj Mahal is not only because of its beauty of architecture above the soil but also below the soil. It is a foundation which holds the Taj Mahal still strong till today. Coming to cornea, endothelium acts like a foundation. In any damage to endothelium, no more, you have your epithelium and stroma standing strong. So here comes the topic, what do you do next when your endothelium is damaged? So all the indications will be when your endothelium is unhealthy and stroma and epithelium are healthy. Like fuchs endothelial dystrophy, posterior polymorphous, you have pseudophakic, aphakic bullous keratopathy, IC, so endothelial failures due to trauma, previous surgery, angle closure, tubes, and even graft failure. Choose your candidate wisely. It's important to know in whom you shouldn't be doing cases, also which are high-risk cases, like shallow anterior chamber, smaller eyes, glaucoma with filtering blebs and tubes, presence of ACIOL, absence of portion of iris, floppy iris, and aphakia. All these cases are not that it's impossible, it is difficult, but it is possible. Because the magical portion of DSEK is at tamponade. And in these cases, it's quite difficult. And active macular edema and intraocular pressure should be managed before the procedure. This is a case where phaco plus IOL and TRAB was done elsewhere in 2021. Later, patient developed PBK and I had done DSEK in 2023. The bleb is still active and BCVA is maintained. When do you do what? Generally, it's preferred to do cataract surgery before the transplant, either staged or combined. You have either one set of patients where early fuchs with a cell count of 1,700, 1,500, you can go ahead and do phaco. Use enough of viscoelastic like Viscot to protect endothelium. Prime the patient, that patient will be needing DSEK later, and then that's your way. Sometimes you have patients with clinically significant edema and there's no doubt, just do a combined procedure. But most of the time, what we face is the patients which do not fall into category A or B will be in between, where relatively clear cornea, but clinically edema has not developed. Then what do you do next? Take specular microscopy and see the cell count and thickness. When your thickness is above 600 and your cell count, cell density is below 800, it's a red flag sign that you can do a combined case. For example, when a patient came here with 625 cell count in right eye and 811, you can see the CCT is also increasing. In these cases, you can do combined, because if you touch the cornea, very soon they're going to relate with non-resolving corneal edema and you'll be blamed. Donor details, uniform thickness. Any thickness less than 180 is good. Thinner the graft, better results, but very thin graft is quite difficult to unfold. Diameter, take 3 mm less than the smallest diameter of the recipient cornea. So you measure your recipient cornea and take the smallest diameter. From there, you minus 3. The most common size which is used is 8 to 9. You keep this 3 mm interval is because you don't want the graft to reach the periphery and keep kissing the iris, causing angle closure and further damage. For example, this is a DSEK which I had done before, and you can see inferiorly, the iris and the graft is almost encroaching and touching, and there's kind of retrocorneal membrane type of fibrous membrane which has formed. The shape of, you have a meniscal shape which is commonly seen in microkeratome and femtosecond. Meniscal are thinner in the center and thicker in the periphery. You have 1.5 diopter hyperopic shift. See, whatever you add in cornea, the corneal thickness is increasing and obviously there's a hyperopic shift. So in such patients, you are planning a cataract surgery, keep your IOL myopic so it gets neutralized during surgery. And generally when we do a manual dissection, you get a planar shaped endothelial lenticule and they have less chance of a hyperopic shift. The stromal bed consistency should have a smooth bed. Femtosecond followed by microkeratome and manual dissection, smoothest in femtosecond. Rim size, this is one point which you have to have extra than a total PKP indicated grafts. Like you have to have minimum of 2 mm. This is because you have to mount the graft on an artificial chamber and you have to have some amount of sclera to hold on to the mount. So if you have less than 1 mm, it can cause loss of vacuum or loss of suction, can cause buttonholing and even perforation. Coming to endothelial count, anything more than 2,200 is a good sign. More the count, more the reservoir, more the pool, it's always better. Donor age, 2 to 75. Though it is told as 2 to 75, age above 25 will be better because they have better scleral rigidity. And younger age have decreased scleral rigidity. It will be difficult to pass microkeratome. Even your manual dissection can result in perforation. This is one of the video. It's my video where I put viscoelastic on the artificial chamber, have kept the graft. And you have two rings. One is to hold the graft and one is to tighten it. And once that is done, you can check for leaks with vitreous wick. And if there's no leak, you can go ahead. I generally use a 400 micro blade. 300, 350 and 400 all are available. Make a bold incision vertically around 4 to 5 mm. Concentric to the limbus. Then you use a blend dissector. This is double-headed blend dissector, and you go very slowly fanning motion in both sides and reach till limbus. You can see even my left hand is moving, angulating to the direction I want. Once you reach half of the cornea, you shift the blade into the vaulted or the curved blade, because cornea is prolate. When you go with a straight blade, the chance of perforation is more. And then you make sure you reach the limbus. And once that is done and all areas are covered, you can come out and you can mark the incision site so that when you do the next trephination, you can avoid this area. Release the vacuum of the artificial chamber and then slowly remove the ring, and your graft is ready for the trephination. Now coming to the recipient cornea, remove the epithelium. Take the pupil, corneal center, taking the marker from limbus to limbus and half of it. Keeping that as a guide, take another staining trephine to just mark the epithelium. Reform the AC with visco. I have already stained the endothelium with trephine blue, so it will be easier. Using reverse Sinskey hook through the side port, you can score the endothelium. So this circle which is there on the epithelium will act like a guide, and you score all the way full circle, 360 degree, and only then start your peeling. So once that is done, then you can go into AC and gently start peeling. Here you're trying to not touch the posterior cornea, because each time you touch, you can invite strands from posterior stroma. Here only the folded part of the DM is slowly brought from periphery to the center. Since it's stained, it's pretty clear, you can see it. And the center is always done last to prevent minimum touch. And once you reach the center, you can remove the Desmond's membrane through the reverse forceps. And then you can take it out and keep it on the cornea, spread it out gently, and see, you can get it as a single sheet. And this is very important because this helps to know whether you have some remnants or some tags which is left behind. And you have got a single sheet and it's all done. I have used sheets glide, put visco, flip the graft over the sheets glide, and then with a blunt spatula, remove the anterior portion of the cornea. And then you can use a 26 gauge needle, which is the same needle which is used for capsular excess. You can just push the graft into AC, and then once the graft is in AC, just form AC, don't worry about the centration. And then next most important thing is suturing the wound. Only once the wound is sutured, you can think of positioning the graft, and then with a gentle movement over the epithelium towards the direction you want. Like you want the graft to move inferior, then you move the cannula superior to inferior, then you hydrate all your side ports, keep all your openings closed, because you need, next is the increasing the air tamponade level to almost 95 to 100% air. So now it's almost 100% air, and then you leave like that for another 10 minutes. The first 10 to 15 minutes is most crucial, and then you can just press the posterior lip of the side port and release the air to around 75 to 80%. Though you ask the patient to lie down for next 24 hours supine, the most crucial part is the first 10 minutes. If the graft is attached in the first 10 to 15 minutes, it will surely be attached. Then with the vitreous wick, you can just milk out at the venting incision, check for any leaks. Generally, venting incision is always put in the mid-periphery, not in the center or extremely in the periphery. So this helps in removing the fluid or air which is trapped in the interface. This is a Melius technique, the manual technique which I do. But if you have the luxury of vacuum trephine, you can go ahead with Hesburgh-Baron vacuum trephine. You have microkeratome dissections, and you have even femtosecond laser assisted. You can have the ablation, which is in the center reaching to the periphery. And there are different technique to push the graft into AC. The famous tacker-fold, 60-40 tacker-fold using forceps. Make sure that the forceps are not meeting each other. But generally, these procedures are not done nowadays because it can cause crushing injuries over the endothelium. You can also use a spatula where the graft has been placed on the spatula, coating the viscoelastic on the endothelium, fold it and use it. You can use Bunsen guide and also Tano endoglide. You can also use a suture pull-through technique where the end of the suture has been tied to a knot and then pull through the paracentesis wound. You can use an inserter too. This is one of the cases where DSEK was done by one of my friends where the graft is attached but edematous. She didn't know what was going wrong. I had taken an ASOCT photo where you can see there is one end of the graft is attached, the other end is detached, and then the graft is very edematous. So the thing is, when all your ends in the periphery are attached, even if there is a thin gap, it is going to attach for sure. But if there is a detachment in the periphery, there's a constant aqueous flow which is flowing and it's not going to get attached by itself. It will need an air bubbling. So same case post-op 8 months. You can see how the graft cleared and vision maintaining 6-9. This is a photo where I had done DSEK for my own auntie. My auntie had fuchs endothelial dystrophy, and I had done DSEK and BCVA maintaining 6-6. And I also put an ASOCT thickness showing 92 microns, and thank you.
Thank you, Dr.